We're going to get started. Take it away, John Ross.
Thanks, Michael. Good evening, everyone. My name's John Roth. I'm an attorney and a proud board member of Primary Care for All Americans. On behalf of the board, I want to extend a warm welcome to you all for tonight's teach-in, learn, and Zoom session. Thank you for joining us. With over 1,200 people from 40 states, the District of Columbia, and more than 350 zip codes, we're reminded that the incredible momentum we've built together to provide primary care to everyone in America continues to be a movement fueled by your dedication and commitment. Tonight, we have the pleasure of learning from Alana Krolikowski about maternal health, about how maternal health is an integral part of primary care. It's now my great pleasure to introduce our moderator for this evening, Chioma Nwangwo, and to extend my sincere thanks to all of the presenters for tonight's event. I'd like to thank Primary Care for All Zoom Committee, as well as John Wright, Brian Kaiser, Patty Armstrong, Alan Roth, Liv Verratti, all for organizing this event. So Chioma, please take it away.
Thank you. Please take a moment to share where you're joining us from in the chat so we can all see who's here as we work together to build this movement. And as we do, let's refrain from using professional titles, please. This space is about focusing on the importance of being here together, engaged in this work, and valuing the ideas and commitments that will ultimately drive this movement forward. Now, it is my great pleasure to introduce our keynote speaker, Alana Krolikowski. Alana is the Chief Medical Officer for Jericho Road Community Health Center in Buffalo, New York. Her work focuses on comprehensive primary care, maternal child health, and healthcare capacity building. She went to university at Buffalo Medical School and trained in family medicine in Lawrence, Massachusetts, at a federally qualified health center, and was a founding faculty member for the first postgraduate family medicine training program in Malawi. She serves on the boards of a community-based safety net primary care association and on the YMCA Buffalo Niagara. Tonight, we are here to both teach and learn from each other. We encourage you to contribute by submitting your questions in the chat throughout the session. Please stay with us at the end of the session, where we will have time for a Q&A and discussion. We will be exploring how you can help bring primary care to everyone in your own neighborhood and community. Now, without further ado, let's dive into tonight's topic. Take it away, Alana.
Good evening, everyone. Thank you so much for the introduction, and I'm really excited to be here with you all tonight to talk about a topic that is of personal and professional interest to me. So a little bit more about myself. I grew up in rural Western New York in a small town, came up to what I call the big city. So not New York, LA, or DC, but big city for undergrad and then medical school. I decided to become a family doctor because I love taking care of families, taking care of patients, like we say, from womb to tomb. So I love the maternity care aspect of what we do. And when I did residency in Lawrence, Massachusetts, I was able to get good training in that. And that's really important that we have training opportunities for people to do this type of work. After finishing residency, my husband and I moved to Malawi, where I was in a teaching capacity. I worked at a rural district hospital, and for 6 months out of that year, worked in the maternity ward. We've been back now for just under 10 years, and I've been at Jericho Road Community Health Center that entire time. And in the last 10 years, I've also had 3 children. So my kids are 8, 6, and 3. And a lot of thoughts about, the personal experience of being pregnant and seeking care. So definitely this is an area of both personal and professional interest. So let me tell you a little bit about Jericho Road in general, and then about our maternity care model that we have. So Jericho Road was started as a private family practice in 1997 by Dr. Myron Glick. He is our CEO, and he's a family doctor. We became a federally qualified health center in 2013. And today we serve just under 25,000 unique patients every year. We have 5 clinical locations in the city of Buffalo, 4 of which, at 4, we provide maternity care. One of our sites is inside a men's homeless shelter, so we don't have maternity care there. But we do have comprehensive primary care, maternity care, integrated behavioral health, pharmacy, dental, physical therapy, fitness center. We have care management and care coordination services, a number of health-related social needs programming, one of which I'll tell you about in a little bit. And then we do have health facilities in Sierra Leone, Democratic Republic of Congo, and Nepal. Our maternity care that we provide, I'd like to say, is an integrated model. We provide it alongside and together with our primary care. So we have a number of family doctors, family nurse practitioners. We have a women's health nurse practitioner. We have one of our providers is a women's health nurse practitioner, FN, family nurse practitioner, and certified lactation consultant. So, and we have pediatricians on staff. And we provide primary care and maternity care in an integrated way, either by the same clinician or a different clinician, but within the same spaces. We have integrated scheduling, electronic record, all of that's the same. We have continuity of care between settings. So in the office and in the hospital, we have a number of people who provide prenatal and postpartum care in the office. And then we have a team of family doctors who deliver in the hospital. The program that I mentioned earlier is called the Priscilla Project, and that is a maternal health program where we have maternal health community health workers and doulas, and patients can opt into receiving those services. We care for a very diverse patient population. Over half of our patients prefer to be served in a language other than English, and we care for patients from all over the world. So that's a whole lot of different languages. We do our best to match a patient with a community health worker and or doula that speak their language and or from the same culture. And I can tell you as a physician that delivers that when I can be in the labor and delivery room with a doula who speaks the patient's language, who has a relationship with that patient, it's really very important, makes a big difference in their care. And so having that integrated model available for our patients is really important. We are able to provide integrated newborn and postpartum care. When I'm in the hospital after someone delivers, we take care of the moms and the babies together. When they can then come into the office, we can take care of mom and baby on the same day, either with the same clinician or with different ones. I know that there's different models out there where people want to screen for depression and family planning needs at newborn visits. We're able to do that seamlessly, either with the same clinician or with someone else. Having access to behavioral health allows us to refer patients seamlessly to those services when they need them and provide breastfeeding support for patients. So I know that there's all different models out there, but that's gives you a sense of the model that we have. And I want to tell you a story of a patient that I saw last week. So this patient has been with us for many years for primary care. And she was on my schedule last week for a physical, a regular preventive visit. And when I was looking through her chart and talking with her, I saw that she didn't have a physical or preventive visit, technically, since before she had her first baby 3 or 4 years ago. But what I noticed is that all of her preventive care had been addressed during that time, during her maternity visits, prenatal and postpartum, and she felt that all of her needs had been met. And now, around 11 months postpartum from her last baby, she was coming in for a regular preventive visit. But our system that we exist in right now would say that she didn't receive her preventive care because she didn't have that preventive visit. But what we know is that the maternity care model integrates multiple aspects of healthcare, including preventive care, chronic disease management, mental health, connection with social services. So midwives, family doctors, OBGYNs, they're trained in well woman care as well. And women are getting these services while they're receiving their maternity care. This provides a holistic approach, and preconception care is really important. Not everyone seeks that for a variety of reasons. We know that prenatal visits might actually be a woman's first and most consistent healthcare interaction. and it's an opportunity to screen for and address chronic conditions. 30% of the United States, 30% of the adult population in the United States does not have a usual source of care. So it's not uncommon that these prenatal visits might be the first time a woman's come into care in quite some time. Embedding maternity care within primary care settings is important for health systems to ensure continuous comprehensive care for families and can reinforce access to primary care and build trust that's really important. People who receive respectful, culturally sensitive maternity care are more likely to engage with primary care for themselves and their families, and this can lead to long-term patient-clinician relationships. I really believe in expanding family doctors and midwives who incorporate maternity care into their practice. This will increase the overall primary care workforce, especially in disinvested communities. So why does this matter? There's a lot of reasons, but I'll share a couple. We know that in the United States, our maternal mortality rate is 21 deaths per 100,000 births. And this is higher than many high and middle income countries. So this compares to 14 in Russia, 8 in France, and 5 in Ireland. So our maternal mortality rate is 4 times that of Ireland. I'm in New York State, so we had a primary care scorecard that came out last year. 25% of pregnant women did not receive adequate prenatal care. And that was worse for Black and Latina women. For Black women, only 33% did not have adequate prenatal care, so only 67% did. We also know that the maternal mortality rate among Black mothers is 3 times higher in New York than compared to the national. So it's 65 per 100,000, and this is 4 times higher than white mothers in the state of New York. There's other states where it's worse than that, and this is unacceptable. Our system is not working for women, and it's not working for everyone in general. We need a system that focuses on primary care that includes maternity care. I'm going to jump from moms to babies. We know that the first 1,000 days of a child's life are really crucial, from pregnancy to age 2. It's a really important window of opportunity to create healthier, brighter futures for our children. Nutrition plays a foundational role in a child's development and in our country's ability to prosper. This can affect their ability to do well in school later on, affect their ability to graduate high school, go on and do better things after. And it sets the stage for later chronic diseases if people don't have access to good nutrition. There's studies that show that countries that fail to invest in the well-being of women and children in the first 1,000 days lose billions of dollars to lower economic productivity and higher health costs. So we right now have a $2 trillion operating deficit as a nation, and we want to figure out how to save costs, talk about governmental efficiency. If we could invest in women and children, we could have increased revenue from taxes, having more people that are productive in the workforce, and we could lower healthcare costs. So increase our revenue, lower our expenses. Examples of investment include prenatal care and nutrition programs, breastfeeding support and promotion, early childhood education and development programs, and home visiting and parenting education. And I'll say something about that last one. At Jericho Road, we had a Parents as Teachers program and a Parent Child Plus program, which are nationally recognized programs to invest in children, and we could not keep them funded, and we had to close those programs. This is an absolute shame, and it gives an example of how challenging it is on the ground for community-based practices and the really difficult decisions we have to make, even though we know that these things are really important. So we as a nation need to do way better. It's not just a moral imperative, it's an outcome imperative, it's an economic imperative, and it's a national security imperative. I don't know if any of you have read Political Determinants of Health. It's a really good book. It's a good way to think about health in this country. And that's all I have for now. I really appreciate the opportunity to speak with you tonight, and I'm happy to take any questions at this point. Thank you.
Thank you so much, Alana. That was very insightful. If anyone has any questions for our keynote speaker, please post it in the chat. By joining and learning how communities provide primary care to everyone and bringing one new person or one more person each week, we'll build this movement together. Our work groups still need more people to roll up their sleeves and be a part of the work that we are doing. Please click the volunteer button in the Contact Us section of our website and tell us how you can help. Together, we can make sure that everyone in these United States receives equal health care and gets equal health, regardless of where you live, how much you earn, what community you're from, or what you look like.
Chioma, thank you so much for emceeing tonight. This is your first night emceeing with us, which is amazing. Can you tell everyone where you're in with your schooling and your medical career?
Sure. So I am a fourth year medical student. I will be matching next week and I'll be graduating in May.
That's very exciting. Thank you so much for hosting. I know we'll have you back on in just a minute, but this is part of what it means for us as an organization to have people come and step up and present. So thank you for doing that. And as we go to some questions over here, we'll have Alana come back up. Alana, I have a deep appreciation for what you shared about today, both from the work that we are doing around primary care and setting behavior, but also as a mom myself and knowing that for when I was going through my experience, I didn't go see my primary care physician for that period of time because I was seeing a doctor every other week for a while. And so while I feel very privileged to have had that experience, I am surprised but not surprised that 2 million women in the US are found in these maternity care deserts. So when we look at these communities, when we start thinking about how we are supplying primary care, how we are connecting people right from really the beginning, how can we be better in our own communities with maternity care?
Yeah, that's a really good question. And, it's affecting communities all over the country. So in Western New York, we have 8 counties in Western New York. And in the last 5 years, 4 hospitals have closed their labor and delivery units. There is 1 hospital left doing maternity care in Niagara County, for example. So people know Niagara Falls. Right there in Niagara Falls is the last hospital in that county. And we actually are starting a partnership with a federally qualified health center in Chautauqua County, which is south of where we are, to have a couple of their doctors join our call pool and start delivering their patients in Buffalo, which is like an hour drive for these patients, but it's either an hour north or 45 minutes the other way. So it's tricky. I think what people can do is advocate for your local community health centers, maternal health facilities, doulas, doula billing, doula reimbursement. If that's not something that's happening in your state, advocate for the rural critical access hospitals that are really struggling to stay open, and for midwives, family doctors, and OBGYNs to all provide this care in a collaborative way. If there are nonprofit hospitals in your area that are not investing in maternity care, then you need to hold them accountable. They receive substantial tax exemptions to provide community benefit, and we need to hold them accountable to that community benefit spending.
Yeah, and as you're mentioning the spend side of things, I know like funding sources is a big question, how you guys manage that. Pat Tokars dropped a question or two in the chat. Pat, are you available to pop off mute and ask your question directly? Well, so I think, Pat, you can interrupt me if you find that unmute button, but Pat asked, how much money would it take for your system to provide all the primary care your community actually needs? And what are your current sources of funds?
Those are big questions. I guess I would direct people to, so there was a report that came out from the National Academies of Science, Engineering, and Medicine in 2021 called Implementing High Quality Primary Care. And every year since then, there's been a scorecard that's been released, including just in February, about the health of primary care in the United States, talking about the primary care spend, which is around 4%. So all of the healthcare money that we spend in this country, it's about 4%, depends on which insurance. But that really needs to be in like the 12% range. And so I don't know that I can give an exact dollar amount, but we are seeing patients over and over and over fast, not a lot of time. That's not what patients or providers want. They want to spend time with their patients. Patients want to be seen on time. They want to have time to talk about all their issues. So, there's that. So there's the total primary care spend. And there's also like we for our patients at Jericho Road, 77% have Medicaid, and Medicaid is paid so much less than Medicare and commercial plans. So we need payment parity. I don't know if I can give you an exact number, but our funding sources are insurance companies. We're federally qualified health centers, so we get some enhanced reimbursement for our visits that are Medicaid managed care. Some access to grant funds, but yeah, it's tricky.
Well, and it might help. Michael has suggested that it should be 15 to 20%. So that would also boost you as well in what it would be available. George has a question for you. What I would love to do is go through and just let people know what's coming up. And then once we get to just about 5 minutes from now, come back to his question about sort of the integration of what your program does with other health resources. So if we can pause the questions for right now, we will have an opportunity in just a few minutes to dive back into questions. But I would love to pass it over to Michael Fine to talk to us a little more. Michael?
Briefly, thanks, Alana, for that great information. It's a scary thing thinking of 2 million women in the United States living in maternity care deserts, a number that's growing. We live in interesting times, which is not always a good thing. And nobody knows what's going to come out of Washington in the next days or weeks or months. But everybody knows that all Americans need primary care, and that all women need maternity care, and that we ought to be working on this together. So let's get involved. It's not coming from DC. It's probably not coming that much from state houses. It's going to come from the bottom up, community by community. We just saw last night the little city of Central Falls, Rhode Island, passed a resolution. The city council determined that everybody in Central Falls ought to have primary care. We've seen other resolutions like that around the country. That's what happens when you get communities involved. And that's the way it's going to happen. It's going to happen when you get your hand on one person, sit them down in your neighborhood, in your living room, in your kitchen, and say, how can we do this and fix it right here and get to work and start one of our local work groups. We've heard of 2 new local work groups starting just in the last couple of weeks. We're thrilled by those, but 2 ought to be 10, ought to be 20, ought to be 50, ought to be 100. And that's the way we build a movement that changes the mess. Alana, you kept calling it a system. It just isn't a system. It's a mess. Or better, it's a market that's there to sell stuff. It's not a system that's there to take care of people. You can do this. We can do this. We can do it together, and we must, because there's no one to do it for us. There's no one better than you, and no one better than us to build that healthcare system for all Americans starting today.
Let's continue growing and making a difference together. Mark your calendars for our next Zoom meeting, Tuesday, March 25th, when we'll be diving back into the PC4AA local playbook. We look forward to seeing you there. Have you seen and shared the PC4AA local playbook? Ready to take that next step with one other person and put the power of 2 into action? Register on our website, www.primarycareforallamericans.org. And while you're there, click the volunteer in the Contact Us section of the website to tell us how you'd like to be a part of our movement. And please click donate to support our efforts with a contribution. Every little bit helps and makes a big difference in advancing our cause. Now I'd like to introduce one of our board members, Julie Foucher, who will be here to share why donating to Primary Care for All Americans is so important.
There we go. Now I'm unmuted. Hi, everybody. I'm Julie. Thank you so much, Alana, for that talk. It's definitely something that is personal to me as well now, as I'm actually getting married in the fall and thinking about having children of my own and thinking really about the accessibility of maternal care. So thank you for sharing that. And Michael, for the riveting and motivating speech as always. I'm here to talk a little bit about monthly donations. This for me was something that a couple of years ago, I spent a lot of time reflecting on for myself. What are the ways that I wanted to give back to certain organizations monetarily and be really intentional about it. Things that, there's always things that come across, through the mail or through our email of organizations that we can donate to. And there are so many great causes out there. But for me, I realized that I wanted to donate to things that really pulled at my heart and were things that I was really passionate and really cared about. And so now, one of the ways I've decided to do that is as a percentage of my income, and thinking about it intentionally, either at the beginning of the year or this is a great time. I know everybody's thinking about it as they're reflecting back on last year and we're doing our taxes. For me, one way that made that really easy was just doing a monthly donation. So I knew that the organizations I'm donating to, it's just coming out as a monthly donation. It's something I don't have to, think about a lot throughout the course of the year. And it's great for the organizations as well because they're having more stability over the course of the year. And so, as one of those things for me, there's a few different things I'm passionate about, but one is definitely primary care. And I was so grateful to be a part of this organization as a board member. And I think why I believe in it the most is because of the people that have come together and the mission that it truly is from the ground up. It's grassroots. It's, people, healthcare for people, not for profits. And so it was very aligned with where I wanted to put some of my annual donations towards. And I love that we have the opportunity to give on a monthly basis, on a recurring basis, so that it's something that I don't have to think about. I just do it every month. It's great for me. It's great for the organization. And so I'd encourage anybody listening, if primary care is one of those things that pulls at your heart as well, this is a great organization to support. And if you're going to consider doing it as a monthly donation, you can also think about it as, instead of buying a latte once a month, put that money, towards primary care for all Americans. It doesn't have to be a big donation. It can be $5, $10, whatever feels great for you. So thank you all for joining.
Thank you, Julie, so much. We really appreciate you hopping on and sharing how you give back in this way, not just through the work that you do, but also financially. So thank you for your contributions. And thank you, everyone, for joining us tonight. We appreciate every single one of you, what you bring to the table, how we are making this movement happen across our nation in order to get the change you deserve. Take a minute. There is a survey available with a link in the chat. So let us know what we are doing, how we can do it better. We want to hear from you, and we'd like to offer the opportunity to talk with members of the leadership team and continue the conversation for just a little bit longer with Alana about, the things that were discussed this evening. So stay on our call, but if you have to hop off, we will see you on March 25th. At this point, I'd love to have Alana come back on as we talk through some of these different things that we mentioned before. Specifically, I had seen something from George about the having a discussion about how Alana's program relates to other health resources and sort of what I would call integrated, but I am non-medical, so I'm probably using the wrong terms. George, did you want to elaborate a little more on your thoughts?
Sure. Thank you very much, everybody. This is wonderful to be a part of this group, this spirit. It's long overdue. I spent a long time in Europe, and they have, as some of you probably know, a totally different approach to primary care, and it works. And they have a much lower rate of chronic disease. They have much better infant mortality rates, et cetera, et cetera. And we can talk about all of that. I just wanted Ilana to congratulate you on what you're doing. It is just Sisyphean. I don't know if I'm pronouncing that right, but it's a tough job you're doing, and you're to be commended for doing it. What I'm interested in, or what we are interested in, is how other sort of non-traditional resources can be brought to bear to groups like yours. And to try to sum it up quickly so I don't keep people, the basic idea is that we're not going to graduate or teach our way out of this crisis. That's important, obviously, to keep adding doctors, family physicians, primary care physicians. But if you look at and extrapolate the numbers, it's not a pretty picture in terms of the number of primary care family doctors that are needed. So here's just an idea to think about. What if we took a lot of the advances that have been made in other domains, like the data analytical, AI, cognitive behavioral psychology, all of those different sciences. We've made enormous strides. Just to take one example, it's still very difficult to get patients engaged in their health sometimes. But we have, in the last 10 years, there have been some big strides made in that. We can talk about examples of that. And the basic idea is that because we now have telehealth, and we have, in many cases, connectivity to telehealth resources that can connect, primary care doctors and family care doctors to patients in their home, at their work, wherever, and that there are now what are called knowledge repository capabilities that basically are screened and culled peer-reviewed literature that has been extracted and put into what are called knowledge nuggets. And those knowledge nuggets are then made available to people as they are, and to practitioners as they are dealing with patients, maybe over the phone. And instead of talking about episodes of care, you talk about micro care encounters, where somebody who's a health coach is working with somebody and senses from their response to refinement questions that were sent out by an AI engine about a particular.
Can I jump
Yep.
in for a second?
Yep.
I'd like to hear everybody's thoughts about this. I have a different view. I think the center of primary care is the relationship itself. And I don't see that there is a coherent or easy way to offload that onto somebody else. I personally think that we need to quadruple the number of primary care people we're training and do that tomorrow. There's a good business case for doing that. The thing that's getting in the way is the lack of a social movement pushing the country in that direction, and that's what we're here for. But I'm curious to hear what other people think.
Yeah, I mean, I think that sort of approach might work for some people. I can see that not working too well in the patient population that I work with. When COVID started, we pretty quickly shifted to doing a lot of telehealth with our patients. But it's a struggle. We have broadband issues. I mean, we've been talking about this recently at our practice. There are areas in this country that have really been underinvested, even like from a broadband perspective, and trying to access. Like I go through areas of the east side of Buffalo, and I lose my cell phone signal. A lot of our patients don't have access. I mean, they might get on a phone and like you can kind of see. I remember trying to do a video visit with a rash, and it's like I can't even see what that rash is. It's so blurry. So now that, everything's obviously back in person, it has been for a really long time. We have some utilization of those, audio visual capabilities, but not a whole lot. So I think it kind of depends on the population that you're working with and what patients do prefer relationships. I think not all, but I think a lot do.
Wendy, I see your hand raised. Where are you joining us from?
Boston, Massachusetts. So I agree with Michael and with Alana. I mean, I think it's relationships. Having worked in FQHCs for 20 years with Alana for part of it, I agree with certain patient populations, but even for the ones we think, Michael knows this, I work at One Medical, which uses a lot of tech. The patients still want the relationship. And I will say when it comes to maternity care, what shocked me going into a population that I would not have thought needed help from a non-OBGYN around pregnancy-related care, how much, because there was no relationship in the industrialized OBGYN models of the big academic health centers, the patients were coming to me for the relationships. I don't know what to do about this. 50% of maternal mortality happens postpartum. It's mostly, it's mental health, it's cardiovascular health, it's addiction, it's primary care. It's the lack of primary care. And so all patients, I would say, want that relationship. Now, George, one thing you did say that made me think is if you could get doulas paid for, going back to what Alana said, and doulas were partnered with pregnancy care clinicians, so family doctors, OBGYNs, midwives, and you could use them to help with more touch points, that would be fantastic. But I think it gets back to still you need the humans. But you can have tech. I love tech.
I'm not advocating that the relationships would go away. What I'm advocating is that the people the practitioners, the doctors, the nurses, the patients who are in these wonderful relationships, they are in a difficult situation right now because it is very hard to get the right information to the right people at the right time. But now we have tools that enable that to happen. So you can take a lot of the data collection, data vetting, data analysis, guidance preparation, and documentation preparation off the hands of overworked, burned out, overburdened clinicians and doctors and nurses, and put those tasks in the hands of systems that do this very well now, a lot better than was true in the past. And so you get a new division of labor where the doctors can focus on being doctors and practice at the rather than trying to figure out how to work an electronic health record work. And so there are a lot of ways in which these new capabilities can enhance and increase the capabilities of an individual doctor, individual practitioner. And then if you add to that the patient would get access to this data and these tools like remote patient monitoring devices, so they don't have to come in an hour from Buffalo to Niagara or whatever, Alana, you were saying. They can do these things at home with the help of a health coach who knows how to do this. I think there is a way to reduce the burden off of clinicians of things that frankly they're not all that interested in doing, and they're not trained to do it. And so that's I'm not advocating to upset the patient doctor relationship. In fact, I'm hoping that this kind of approach would be able to improve it, give the doctor more time to spend on talking to the patient rather than typing stuff into the EHR.
I'd be interested to hear the perspective from rural Maine. Scott Hansen, can you come up? Are you willing to come off mute and give us that perspective? Oh, I put you on the spot. I'm sorry. Sometimes getting off mute is difficult.
Yeah, couldn't find the buttons. There you go. Thanks, Michael. We've got the same problems in rural Maine that everyone has. Everyone thinks they can do a better job than physicians and surgeons in delivering healthcare, and nobody wants to pay for it. We're trying to figure out how to align the employers and their employees, because with the employment tie into health insurance right now, that really seems like one of the best routes to try to get primary care and other access to everybody, and eventually cut out the insurance companies, maybe.
Scott,
Direct contracting.
Have you read the book The Company That Solved Healthcare by John Turinis?
I haven't.
Take a look at it. It's they actually solved the primary care problem, and it's too long a story to tell right now. And it wasn't by it was by trying to do some of what we've just been talking about, of having an on-site clinic, by having integrated individualized care, and they were able to give the employees data on what were the high value added providers in this southeast portion of Wisconsin. And the data included the differentials in cost, differentials in number of times somebody had done, let's say, a knee replacement or whatever.
I don't think Scott Conard's on tonight, but Scott's done great work about that. And certainly there are opportunities to improve the function of primary care practices and make them more efficient. But I don't think there's anything that's going to replace making sure that we are quadrupling the number of people we're training, so there are enough people to support the work that needs to be done. Now, there's some likely opportunities if primary care clinicians can organize themselves to push back on insurance companies and the other people who create unnecessary work. And that's an opportunity that we haven't developed well. But we kind of have to do all this stuff at once. We gotta come up with technologic improvements for sure, but we've got to lean heavy into workforce. We've got to lean heavily into pipelines and pathways so more people go into primary care. We've got to get better scholarships. I don't know if everybody knows this, but when I came through, there were 1,800 people getting National Health Service Corps scholarships a year that sent us back into communities. Now there are 50 to 100. There are lots of things we got to do, and we got to do them at once. And that's the challenge and the opportunity of building a movement.
Can I add something?
Please.
So I come from this, I don't work in healthcare. I work in healthcare finance and insurance. And so when a doctor signs a network contract on a managed care plan, you're basically giving your rights over to the insurance company to dictate what they will and will not pay for. They don't practice doctoring. They just practice who they're going to pay. And there's other types of insurance out there that don't do that. And I don't know that a lot of doctors even talk about that type of insurance. And at the end of the day, those types of insurances, back when they used to utilize them to help protect people's savings, I mean, we were paying 5% of our GDP was healthcare, and your relationship was directly with your doctor. You guys made your decisions. So, I mean, we might want to think about how we're financing the thing, because that's probably a lot of the problem.
Your thoughts? Penny, take us home. Unless you have more questions.
I was just looking to see if we had any more questions popping up in the chat. I see some good discussion that's happening, which is what we really do want to encourage here. We want to encourage talking to one another as one idea begins to build off of another. This is where we find solutions. So with that, Michael, is there anything else you want to send us off with, or will we see everyone on March 25th?
Well, let's look for everybody on March 25th. We have needs for volunteers. We need people from upstate New York to help with our New York State work group. We need folks to, who are, if anybody's interested in helping edit our newsletter, we have need of that. We need communications people fairly, and not desperately, but we definitely need communications people to help us make sure we stay on message. And we need everybody to talk to somebody in their own community and get started on a local work group, because that's the way this changes. In New Bedford, Massachusetts, the local work group that got started 4 or 5 months ago now has 47 people in the community of New Bedford working on figuring out how to provide primary care for everyone. They figured out that in a city of 100,000 people, there are only 4 physicians taking care of adults. I think if you scratch lots of other communities, you'll find similar things. But nobody thought to ask the question until there was a local work group in New Bedford. This is something we can do together, and the only way to make it happen is if you step up. Thank you.
See you guys on March 25th.